Hi everybody. Today we're going to tell you a lot about birth. We started this seminar years ago because we have a lot of expats in our practice, and we experienced that a lot of people have an unrealistic view about how a birth should go. Today we're going to talk about the Dutch system. We're going to tell you how that works. We're going to tell you about the delivery, a lot about the delivery. We're going to tell you about the role of the partner, about different reasons to be referred to a gynecologist. One of them is pain relief. We're going to tell you about the different pain reliefs. We're going to talk about home versus hospital birth. And we're going to talk a small bit about the postnatal period. Of course, now there is the coronavirus, so everything is a little bit different. Good to know that we keep you updated by our Instagram and by our blog on our website, so read that often, because if there are new measurements, we'll tell you and inform you through that way. Good to know that now, during the delivery, it's possible in all hospitals. If you or your partner have a fever, or if you have symptoms of corona, it's always good to tell us prior to when we visit you, because then we need to protect ourselves with clothes, and sometimes the location of the delivery changes with that as well. But your partner is always allowed to be present at the birth. First, talk about the Dutch obstetric care. The Dutch obstetric care is really different than in other countries. You experienced that already, because here we have a midwife instead of a gynecologist. How it works here is that we divide low-risk pregnancies and high-risk pregnancies. What that means, you're a low-risk pregnant woman if you're healthy and if you don't use a lot of medication. Then you're guided by a midwife during the pregnancy, but also during birth. If you have a higher risk, and that can be because you have a lot of medication, or if you have a twin, or if at the end of the pregnancy your baby is in breech, for example, then you're guided by a gynecologist. And we do constantly during the pregnancy, we determine if you're still a low-risk pregnant woman, but we do that also during birth. If there is a reason why we think there is a higher risk involved, we refer you to the gynecologist. Later on in this presentation, we'll tell you more about that, what the reasons can be to be referred.
Then I will start telling you about giving birth. A normal pregnant, healthy woman gives birth between 37 weeks and 42 weeks of the pregnancy. Most women deliver their first baby a little bit over the due date, so between 40 and 41 weeks. That's very normal. It's good to know that everything that happens before 37 weeks, we call it premature labor. And then it's very important that you call us as soon as possible when you have contractions or loss of amniotic fluid. After 42 weeks, we will refer you to the gynecologist so they can schedule an induction. Sometimes that's already done before 42 weeks. So that really depends how your blood pressure is, how big the baby is, how you're feeling. So we determine the moment of induction together with you during the pregnancy. We will talk about that also a little bit later. It's good to know that 90% of the deliveries start with contractions. Only 10% starts with rupturing of the membranes. It is what you always see in the movies, that it starts with rupturing of the membranes, but it is not that often. If the membranes rupture, it's most times at night, that you're lying in bed and you wake up because you have to pee, and then when you stand up, you suddenly feel that there's a gush of water coming out. Most times it's a little gush, sometimes it's some drips that's coming out. That's hard, because at the end of the pregnancy, many women lose a little bit of urine or have some loss of discharge. So sometimes women are in doubt, like, is this amniotic fluid or is it discharge? The big difference is amniotic fluid will continuously come out of your vagina. So when you're losing some fluid, just be aware and just put like a maternity pad in your underwear and just check again like 15 minutes later. If it didn't come anymore, then you're sure that there's no amniotic fluid. But if it continuously drips out, then you know it's probably amniotic fluid. Sometimes it can be quite a gush, that it can be like a glass of water that's suddenly gushing out. That depends, of course, the position of the baby and also how much amnion fluid there is in your belly. Most times amnion fluid is clear. It just looks like water. Sometimes you see it a little bit pinkish in it, or you see a little bit of white flakes in the water, but normally the color is completely clear, transparent. Sometimes if the baby pooed in the amnion fluid can be brown or greenish. That's not very dangerous at that moment. It can just happen that the baby just poos during the pregnancy and then it changes the amnion fluid. But for us, it's important to know because sometimes the baby poos in the amnion fluid because there was a moment of stress with the baby. So if we see that the baby pooed in the amnion fluid, we want to do extra checkups. We want to refer you to the gynecologist and to do extra checks to make sure if the baby is doing okay. Most women the contractions will start within 24 hours after the membranes ruptured. So it can happen that at night the membranes rupture and you don't feel contractions right away. Just go back to bed, try to sleep a little bit. There's a big chance that it will start the day, the next morning, and it can even take like 12 or 20 hours before it starts. So just don't sit up and wait for the contractions to start. They will wake you up if it happens. But it's good to know that most times it starts before 24 hours with the contractions. Sometimes it doesn't, and then we will refer you to induced labor. It's important to know that as long as the membranes are intact, there is a barrier between the outside world and the inside world. So bacteria cannot not go into the womb. But the moment the membranes ruptured, a bacteria could go inside the womb. That's why it's very important for us to know when the membranes are ruptured, because then we want you to give birth within at least 3 days. The first 24 hours, there's a very low risk of an infection, because we know that the amnion fluid will just flush all the bacteria away. After 24 hours, there's an increased risk of infection, and that's why we will refer you to the gynecologist if the contractions didn't come after 24 hours. The chance of an infection again is very small, but we want to know exactly when the membranes ruptured. So if you're not sure, if you're losing some fluids and you're not sure if it's amnion fluid or not, I repeat, just put a maternity pad in your underwear and check. And if you think the membranes are ruptured, then write down the time that it happened. So then later when we talk to each other, I can know for sure how late that was. So when you should call us is if the amnion fluid is clear and the head of the baby is descended in the pelvis, and I will show you what that means. This is your pelvis. At the end of the pregnancy, the baby is probably with the head down, and some babies are still very high above the pelvis. They're just in this position or this, but most times after like 36 weeks, the babies go down in the pelvis like this. You can imagine when it's in this position and the membranes rupture, the baby will just go down a little bit deeper, and that's good. And we then are 100% sure that the baby cannot turn in a position like breech anymore. When the baby is above the pubic bone, not descended, then and the membranes rupture, it is theoretically still possible that the baby goes in a different position. So that's why we say that if the baby is not descended in the pelvis, it's important that you call us immediately and that you lie down, because then we want to come over and check if the baby is still with the head down and is in a good position. So if it's clear amnion fluid and a descended head, and we will tell you that very clear, very specific, every time you visit us after 37 weeks, we tell you very clear if the head is descended or not during the checkups. Then and it happens at night, then just go back to bed and call us the next morning. Try to sleep as much as possible. If it's colored amnion fluid, green, brownish, or you're not sure, call us immediately, because then we want to do the extra checkups. If the head is not descended, then you call us right away, and we ask you to lie down, just in case the baby suddenly turned in breech or transfertile, then we would like to know that you're not walking around in the house. We will also give this information to you on paper, so you don't have to write it down right now.
What Lotte was saying, 90% starts with contractions. So the biggest chance actually is that it starts with contractions. At the end of the pregnancy, you will notice that you will have more hard bellies. Those bellies, you feel that your belly is getting hard, the muscle of the uterus will contract, and that feels uncomfortable. The difference between hard bellies and real contractions is that a hard belly is uncomfortable, but not really painful. And there's not a rhythm in it, a frequency. With contractions, real contractions, you will start to notice that they will become frequent, like every 5 minutes. Sometimes you will have nights where you have contractions like first every 20 minutes, and you really have to focus on them, and they're different than you used to have before in the pregnancy. So you really have to focus on them, and sometimes they start to be a little bit painful. Then they're every 20 minutes, and they become like every 15 minutes, every 10 minutes, every 7 minutes, and then at some point they go back to every 10 minutes, every 50 minutes, every 20 minutes, and then at some point they're completely gone. That we call false labor contractions. So your body is preparing itself, but it's not the real labor contractions will make the baby come. We'll call them real labor contractions if we start noticing that they're every 5 minutes, every 3 to 5 minutes. Then we know for sure these contractions aren't going away anymore. And it's really different where people feel those contractions. Some people feel them really in their belly, others feel them in their legs, and others more in their back. You don't know prior to the labor where you're going to feel them, so you will have to experience that the moment itself. Those first contractions, also already sometimes a little bit the hard bellies, but especially the false labor contractions or the first contractions in labor, will shorten the cervix. And what you see here on the different pictures is that the cervix is the end of the uterus, and it's like 3 centimeters long. And the first contractions will shorten the cervix and make it softer, and at the end will make it open up. If you never had contractions, the cervix feels like the tip of your nose. It's really firm and stiff, and that's how it should be, because it should hold a baby in for 9 months. So if it's really weak, it will open up with a couple of contractions. But at the end, after already a lot of contractions, hours of contractions, how it feels is like the piece between your fingers, actually. This thin and that flat. If it's that thin and that flat, it can open up to 10 centimeters. And that's what we call full dilatation.
I will tell you how it works. The uterus is like a very big muscle with a lot of fibers. And what Laudi told us is that the fibers can contract during the pregnancy already, and also during labor. Oxytocin is a hormone that will come into your system at the end of the pregnancy, and that's causing those contractions. The more oxytocin there's in the system, the stronger the contractions are. And we really want those fibers to contract really strongly, because the stronger the contractions are, the more pressure there is on the dilatation, and the sooner you're opening up. So oxytocin, that's the hormone we need. Unfortunately, we also have adrenaline. And adrenaline makes the oxytocin decrease. So what's very important is to get your oxytocin level as high as possible, to get as strong as contraction as possible, and your adrenaline very low. Because when you have adrenaline, you have less contractions. Adrenaline is like the stress hormone, so that comes in your system when you're worried about something, when you're nervous, or when you're not feeling comfortable. And that's why we say it's very important that you give birth at a place where you feel comfortable, and also with people around you that makes you feel calm and relaxed, and that you feel as little stress as possible. That's also why in a lot of movies you see that women are playing music on the background and having candlelights. It's not because we think it's that romantic to give birth during candlelight. It's just because women really like that it's very dark and calm, because then your adrenaline really goes down and the contractions get stronger. And also it helps the endorphins to get in your system. Endorphins is a natural pain relief and it's really strong. If you have a lot of endorphins in your system, it's really making you quite stoned, and that's really good. So you experience the contractions still, but they're not feeling that painful anymore. And when the contractions, they're like a wave pattern, and when you have a lot of endorphins in your system, you see that the wave, when the contraction is coming, and then it's going away, and then when it's gone, you see women really almost napping in between the contractions. They're really calm, they're not focusing on time anymore. It's really giving a lot of relaxation. Endorphins kick in most times when you're having about 4 or 5 centimeters dilatation and it's getting really intense. You really have to start working, then the endorphins kick in. So many times, just before the endorphins start, women get a little bit worried. They're like, can I handle it much longer? I still find it very intense. It's getting much worse. That's what they ask us many times. And then we know, yes, the contractions get more intense, but your body will make something so you can handle the contractions. So it's good to know that when you're at the point that you think like, oh, I don't know if I can do it anymore, keep doing it, because probably that's the moment the endorphins kick in and will make you more relaxed and more calm. And then we see many times after the endorphins kick in that women can handle labor much easier.
Also good to know, actually, what Lotte is saying is that a lot of people think that in Holland you have to deliver at home. Maybe this is good to tell you also the reason why we don't have a big preference where you deliver. It can be at the hospital or at home, because what she is saying, you have to feel comfortable where you are. And for some people that is at home, that's the most comfortable place. For other people, that's in a hospital. So we as a midwife really don't have a preference, and you can decide how you want to deliver, in which place, but also with medication or without.
Then something about the duration of the delivery. I think this question is asked us most during labor, like how long is it gonna last? We really don't know. It's good to know that you can say that there are like 2 phases during the delivery, the latent phase and the active phase. The latent phase is the first phase, that you have like the irregular contractions that can come like every 20 minutes, every 10 minutes, that you're sometimes even not sure yet if it's really gonna end up in labor or if it's like false labor. After the first stage of latent phase, then you see that they're getting more frequent. What Laudi was saying, that they get like every 3 minutes, every 5 minutes, and you really start having, you have to focus on the contractions. You can't make any jokes anymore. It's, you really have to focus. That's most times around 4 or 5 centimeters, and then the active phase will start. The latent phase can last quite a while. It can last up to like 12 hours. And that's okay, because during that latent phase you can sleep, you can still go outside for a stroll, or you can watch your Netflix. The active phase, then all that is not possible anymore. You really have to focus, and you're only like giving birth. You're in active labor, and you're probably walking around breathing during the contractions. That active phase we want to last the maximum of 5 hours. We want to see that the dilatation is really progressing very well, and we will check that very often to see how you're doing. So it's very normal that, especially a first baby, it takes up to like 18, 20 hours. It's very normal. So our advice is, don't start counting with the first contraction, because you don't know if it's the first contractions, and it doesn't change anything. As long as they're not frequent every 3 minutes and not lasting a minute, you don't have to count them. You don't have to use the app. Try just to distract yourself. Bake an apple pie. Do something that you're just not focusing on the contractions too much. If your partner is still asleep, let him sleep and just do your own thing, because it is possible that it still goes away. And also the moment when you're both sitting and waiting for the next contractions, it's going to take a very long time. So try to ignore them. Tell yourself that it's not real labor yet. By the time that you're then in active labor, it really helps you if you just only have then like 5 or 6 hours left when you, for the first time, admit to yourself that you're in labor.
Then there are different positions to handle with a contraction. And what I mentioned earlier, you can feel contractions in different ways. You can feel them in your belly, in your legs, or in your back. And depending on where you feel the contractions, it's which position feels the best for you. So also now in the pregnancy, you can't tell this is how I'm going to give birth, because a lot of people, for example, think, oh, I'm not going to give birth on my back. But maybe at the end you have contractions in your belly, and actually lying on your back and resting in between feels quite nice. But if you have a lot of contractions in your back, a lot of people don't feel like lying on your back, because then it's nice if somebody could massage your back, for example. This picture gives you a view of the different ways to handle with contractions. So have a look at it, and of course we're going to advise you at that moment as well what we think is a good position for you, but you can try them as well during labor. And it's also good to change positions sometimes, so not be in the same position all the time, because if you feel them, if the baby, for example, if you have the pelvic again, and if you're lying on one side, the baby is pressing constantly on that part of the dilatation. But if you then switch to the other side, it's pressing on that part. So it's good sometimes to move around as well, so the baby presses on different ways of the dilatation.
And as a partner, you can also help. That when you see that your woman is like lying the whole time on her right side, so you probably won't feel her leg anymore after like 40 minutes on that position. So you can ask her like, okay, maybe it's good to change to the other side. When you're in active labor, most women don't feel like changing positions because they just want to rest when the contraction is gone. But as a partner, you can really stimulate her to say like, okay, let's try the other position, or let's try to take a shower. Or many times women react at first hand like, no, I don't like it. I just want to lie like this. But then when you, convince her a little bit like it might be good, then many times women are very pleased. They say, oh yeah, this is much better. I suddenly feel it in a different spot. So as a partner, you can try to help her to get more comfortable in different positions.
Then there's the second stage of labor. And this is the phase where what you see the most in movies as well, is where you push the baby out. What happens at the end of the dilatation phase is that you feel more pressure downwards. And at some point the pressure gets so hard or so bad that it's like a reflex you're feeling, that you really have to push and bear the baby out. And most of the times, luckily, that moment is when you have 10 centimeters of dilatation, so full dilatation. So what happens at that moment? We see at some point that your contractions are changing. We'll check if you have 10 centimeters of dilatation, and then we start pushing. And in the beginning, you don't know exactly where to push to, maybe, and it feels really weird because for hours long you have breathed the contractions away. So we don't expect from you that right away you push in the right way. But we're going to help you with that. And luckily you have that reflex which guides you towards the right way, and you can't push a baby out in the wrong way. So a lot of women feel at some point the pressure a lot in their back or at their anus. You can't push your baby out in that way. So that's good to know, because we see a lot of women start pushing and at some point they're like this, oh, what's happening? And because they're afraid that they're pushing the wrong way. That's not possible. But first you will feel a lot of pressure towards your back, and at some point, really at the end, you will feel it more towards your vagina where you expect maybe to feel it. But that's really the last 10 minutes of the pushing stage. So that's a small amount. The duration of the pushing stage is, for a first baby, the maximum of 2 hours. And the average is 1.5 hours. For a first baby, that's the case. For a second baby, that's 20 minutes, so it's much shorter. What's good to know, if you have a contraction, we ask you to push 3 times, if that's possible. And what will happen is that you will push a baby 3 steps down. And when the contraction is gone, then the baby goes up for 2 steps. So it goes a small bit at every time. And that's what we want it to go, because your body has to adjust to a baby going through, and also your tissue at the end has to adjust to a baby which coming through. So we don't want it to go too fast. What I said earlier, first you will start pushing towards the back. And what's really normal, because we ask you to push, is that there will also be some defecation. And a lot of people find that really embarrassing, like, oh, is that normal? Yes, that's really normal. I think 80% of women defecate a little bit during birth. Actually, we're really happy when that happens, because it means you are pushing the baby downwards and in the right way. So we're really cheering when that happens, and we'll wipe it away and nobody will see it. So don't feel embarrassed, think it as a good thing, because then the baby is going deeper. What happens then is that the baby will make a turn. So first it will go towards your back, what I said. So first it goes towards your back, but then if the baby is in the pelvic, it will make a turn like this, and then goes underneath your pubic bone here. Because what you will see is that the entrance of the pelvic is oval like this, but the exit is oval in the other way around this. And that's why the baby has to make a turn. Lotte will show you.
It goes in like this, and then it will turn to come out like that.
The moment when it goes underneath your pubic bone, then you will start feeling it on your vagina, and that burns. And that's a really uncomfortable sensation. But if you feel that, know that only a couple of contractions away when the baby is born. So we're gonna be really strict to you at that point, because at that point we don't want you to push the baby out too quickly. So we put a lot of warm cloths against your vagina and ask you at some point to breathe. So your tissue can open up really gently, and the baby will be born gently as well. So we're really nice during birth to you, but at that point we're going to be really strict and ask you to breathe and not push. And sometimes we practice that also one contraction earlier, just for you to see how that goes. Good to know as well is that during the whole process of pushing, we're going to monitor the baby really carefully. A baby can sleep actually during the whole labor, but during the pushing stage it will wake up. Because also for a baby this is an intense moment, because there will be pressure on the head of the baby. What you see a lot of times during the pushing stage at some point is that you will hear the heartbeat drop for a bit. Most of the times as a woman you don't really feel that, or don't really hear that, because you're so busy with pushing a baby out. But as a partner that can sound really scary, because you hear the whole time during birth a heartbeat go like boop, 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 boop. And at some point you hear it like boop, boop. And if you hear that, that sounds scary. Know that if it happens for a short while, that's normal. It's just that the baby reacts on the pressure of the head. And it's also good that it happens a little bit, because we want the baby to be awake and alert when it's born. Because if a baby is still sleepy when he's born, sometimes we really have to stimulate them a lot to breathe when they're out. So a little bit stress and a little bit alertness is really okay. Of course, we'll monitor if it's not going too low or if it's not too long, and we'll be really honest with you about that. So we'll always tell you if it's not okay, but if we don't say anything about it, you can trust us on that it's really okay if it happens.
Maybe it's also good to know that we're always very honest with you during labor. We will never tell you that you're doing great when we think it's not going well or it's not progressing at all. Although a lot of women say, well, you probably say that to all women. No, we're not. I'm not going to tell you that you're doing great when you're not doing it great, because then it's not going to work out. So trust us, and especially during the part of the pushing. because it will really feel that you're pushing against something like a closed door. A lot of women experience the feeling that it's not working. And a lot of women say when they started pushing and they're doing it for like 20 minutes, 30 minutes, they say, it's not working, it's not coming out, I don't feel any difference. And that is true. What Laude was saying, it's really small steps, like 3 steps forward, 2 steps back. But it's not this much, it's millimeter. It's very small parts the baby is going down. So you don't feel that. And you really feel the difference when it's under the pubic bone and going to your vagina. But until then, it sometimes feels nothing is happening. But we will check very carefully and we will check very frequent to see if there's really progression. And trust us, when we say there is, there is. So we're going to be really honest with both of you. And then, finally, your baby is there. This is most times how a baby looks like when the baby is born. Many times they're just hands out, and many times babies start crying right away. Sometimes they're not. Sometimes they're just not crying, but breathing. That's also okay. Of course, we will check the baby right away when it's on your chest. The second stage is like when the baby's born. What we normally do is when the baby's born, we will just put it on your chest. We will put some towels on it and we will dry the baby and put a head on the head of the baby because we don't want the baby to get cold. Then we try to just leave you there for a while. The first hour we call the golden hour because it's a very important hour for you as a parent but also for the baby. It's the first time the baby is like in the outside world. It's suddenly very cold, it's very light. There's a lot of different sensations for a baby. So we think it's really nice for a baby to just be on your skin to skin contact with you, and sometimes also with a partner. So we leave the baby with you and we're not going to do a lot of things with the baby for the first hour because we just wanted to be on your chest. Of course, we will do several things when you're looking at your baby. We check how much blood you're losing. We check if the placenta is already coming or not. It's good to know that when the baby's on your chest, the umbilical cord is still attached to the placenta that's still in your uterus. So the first minutes after the birth, the umbilical cord is still pulsating. So the baby is breathing air just in his lungs, but also getting oxygen through the umbilical cord, how he was getting his oxygen for 9 months. After a while, sometimes after several minutes, most times after about 15 minutes, the umbilical cord stops pulsating, and then we know that the placenta is coming off from the uterus. So we will check that, and when we see that it stopped pulsating, we will check if the placenta is coming out. Then you have to push many times, 1 or 2 times, and then the placenta is born. It's absolutely much smaller than the baby, so it's much easier to get the placenta out. Sometimes we see that the placenta isn't coming out after like 15 minutes, or that the uterus is not really contracting well, and we can't leave the placenta in. So then we have to give you some medication to make sure that the uterus is contracting very well. And that's oxytocin. That's the delivery hormone I told you about before. So that we also bring that with us. So if we see that the uterus is not contracting well, we will give you the injection with oxytocin. Then you see that the uterus is really contracting well, and then many times the placenta is pushed out. There's always blood loss during a delivery. Most times there's not much blood loss before the baby is born. But after the baby is born, when the placenta is coming off, then there is some blood loss. We will of course check if that's all normal. And if we see that you're losing more blood than we would like to, we will also give you the oxytocin injection. When the baby is born and you're still admiring your child, then we will also check if there was a tear, and then later on we can stitch that. Sometimes we have to use an episiotomy. That's that we cut your vagina open to let the baby out sooner, faster. It's quite rare that midwives have to do that because we work with very healthy pregnant women and with very healthy babies. But sometimes we see that the heartbeat of the baby drops or it stays regular, then we sometimes know that the baby just really has to come out. And when we use an episiotomy, we know that the baby comes out several contractions sooner, sometimes 3-4 contractions sooner. And if we think it's necessary for the baby that it really has to come out at that moment, we will do it. We will always first give you local anesthetic, and we will tell you that it's going to happen. So it's never that we're suddenly going to cut you open. We see it coming. So when we see the heartbeat is dropping and it's not going up anymore, then we will tell you, like, okay, listen to me, you really have to push hard because the baby wants to come out. And if it then doesn't come out, I say, okay, I want the baby to be out in 2 contractions. If the baby's not out in 1 contraction, I will give you some local anesthetic, and then maybe I have to use an episiotomy. Many times then women think, oh, no way, and they just really push hard and the baby's out. And sometimes it's necessary and we cut you open. The chance that we as a midwife do that is quite low. There's a higher risk if you're in care of the gynecologist. That's because you're there with reason. So for example, if the baby is in breech position, or if the baby put in amnion fluid, then there is a higher chance that the gynecologist wants the baby out sooner than what your body can do. So then there's a little bit increased risk of having an episiotomy. But good to know, don't worry too much because you won't feel it, because there's always local anesthetic before we do that. When the placenta came out, we will ask the partner to cut the cord. And then we put a clamp on the baby, and the partner can cut the cord. And as a partner, if you don't want to, you can do it yourself, or we will do it. Normally, we will use a clamp. It's like the upper picture you can see here. It's quite big plastic thing that's clamped on the umbilical cord to stop it bleeding. It works perfectly well, but it's quite uncomfortable for a baby because it's that big. So now there's something new. It's called the cord ring, and it's like elastic band that can be placed around the umbilical cord, and that's the lower picture you see. Standard you own in the hospitals is only like the cord clamp. If you would like that we use the cord ring, you can buy them online, or you can buy it with us at the practice. So if you want that, just let us know so we can give you the cord ring. I already told you a little bit about the placenta, but it's good to know that it has to be born within an hour after birth. So we're not in a rush, but it's always born within an hour. If it's not, then it might also sometimes be necessary to refer you to the gynecologist, and then they can give you some more medication. And if the placenta isn't still born after that, then sometimes it's necessary to go to the operation ward, and then the gynecologist takes the placenta out while you're under complete anesthetic. You do not need a cesarean after that, because the baby was just born through your vagina. The gynecologist can go in with his hand and grab the placenta and take it out. So if it's not born after an hour, we will refer you, then the gynecologist will try with more medication, and if that still didn't work, then you will go in complete anesthetic, and the gynecologist will take the placenta out.
Then what Lotte was saying, the first hour the baby stays on top of you because you're warm, and a baby came out of 37 degrees, so even if it's a hot day, it's still cold outside for a baby, so it's really nice to be on top of you. But after the first hour, we're gonna do some examinations. We're gonna weight the baby, we're gonna check some reflexes, we're gonna do an oxygen measurement at the hand and in the feet of the baby, and we all do that in the same room with you, so you can look as well. Then the whole delivery is complete. You had the baby, but good maybe to know to summarize again when you have to call us at the start. Of course, call us when you are worried. That's the main thing. When you definitely also have to call us when you're having contractions. For a first delivery, call us when you have contractions every 3 minutes for at least an hour long. And for a second delivery, contractions every 5 minutes. But for a second baby, it's also a little bit depending on how fast your first delivery went. So we'll always mention that to you at the practice as well. Call us when your water breaks, when it's clear fluid, and the head is descended, call us in the morning. When it's colored fluid, brownish or greenish, or when the head is not descended, call us immediately. And call us when you have a lot of blood loss. A little bit of blood loss is normal, but when it's a whole maternity pad full, please let us know as well. Then the role of the partner. The role of the partner is a really difficult role because a lot of guys or partners feel that they don't have really a role actually, and they don't know exactly what to do, and they see their loved ones having a lot of pain, and they feel useless. Luckily, if you ask people afterwards, women, what helped them the most, we see that most of them say my partner. And even though for your feeling, you haven't done anything, you just sit there, the fact that you were there all the time supporting, that's already a main factor actually in a delivery, if there's somebody with you constantly. And of course, there are a couple of things you can do actively. Sometimes what we mentioned already earlier is nice to massage a back, especially when women have a lot of pain in their back. It can be nice to put pressure on this part of the back, so on the parts of the pelvic here. And you have to press quite hard actually. So don't just tickle a little bit, but really put a lot of pressure and ask, of course, if it feels nice. It's good, what Lotte was saying earlier, sometimes to ask to put another position to stimulate that. It's good to keep on eating yourself, but also, especially in the beginning of the part of the delivery, to ask your woman if she wants to eat something, and to stimulate to drink water or lemonade, something with a little bit of sugar in it maybe. And also stay positive. Of course, at some point, if it takes a long time, or if you see that somebody has a lot of pain, it can be that you think, oh, this is really painful, and oh, this is something I wouldn't like to do. It doesn't help if you say that, or if you're looking like I'm looking now, because it helps if somebody stays positive. If somebody says to you, if you're in labor, wow, honey, you're doing so good. I'm so proud of you. Keep on going. Another contraction. You can do it. Come on. I will breathe with you. Breathe in through your nose and breathe out through your mouth. You're doing amazing. Wow, that was another one. Let's do the next one. If somebody helps you like that, that stimulates a lot more than if somebody says it the other way around. So stay positive. Know, of course, that if you have doubts or if you're uncertain about things, you can always mention that to us, because we can imagine that you feel a lot of doubts. But don't show that to your woman, but ask us and we'll explain you everything.
A lot of women don't talk a lot during labor. They're so focused on the contractions. And it's also that a lot of women, when they're in labor, they don't like us to talk too much. But that doesn't mean that we cannot explain you everything. So when you have any questions, don't hesitate to ask them. And if she doesn't like us to talk, then we just go to the next room and I can just explain everything to you. So it's very important that when you feel unsecure about something, or you have a question, or just want to know something, ask us, because it's important that you are as comfortable as possible. It's important for you, but also for her, because when she feels that you're not sure about something, it's not helping her as well. So for both of you, just be honest and ask us everything that you want to know. And also just enjoy it. As a partner, you can really help it to, what Vladi said, just to stay positive. Sometimes a little joke can be nice, sometimes not. You just have to try. Just don't feel that you can do anything wrong. You know each other, just try it, you're doing your best. And it's really helpful when you're in labor and it's really hard work, and you look at your partner and you see that he's really positive and smiling because your baby is coming. It remembers you that you're delivering a baby. Because when you're in labor, you're so focused most times on the birth, the contractions, that you sometimes just forget that there's a baby coming. And then it really is helpful when you see your partner just being so happy that there's a baby coming. So as a partner, just be positive, be there, and enjoy the whole process as well.
there are different reasons to be referred to the gynecologist, and we would like to tell you a little bit what the different reasons can be. So if it occurs during labor, you know what's going to happen. Before labor, so when you're pregnant, there can be reasons. For example, you have a high blood pressure, or when we doubting about the size of the baby, if it's too big or too small. That can be a reason to be referred to a gynecologist. And that can be a reason why a gynecologist chooses to induce labor. It can be also a reason that if you go over the due date, 41 or 42 weeks, that we refer you and that the gynecologist induces. How that's going to go, we're going to explain you, of course, at that moment itself, because there can be different ways how to induce, with hormones through a drip, but also with a gel or some tablets or a balloon. So that is something that at the moment itself we're going to explain you. And there can be also a reason during the pregnancy already that you will be referred to a gynecologist. If a baby, for example, is in breech, that they decide not to induce labor but to do a cesarean. How that's going to go, of course, the gynecologist is going to explain you at that moment as well. But good to know about a cesarean is that a cesarean, the thing itself, it takes really short actually. A baby is out within 30 minutes, but the process towards the cesarean and afterwards takes sometimes a little bit longer. So they have to prep you with an IV, and sometimes you have to wait for a longer time in the waiting room from the OR. And after the baby is out, the baby will on top of you for a bit, and you will get to know each other for a bit. But then the baby goes out the OR with your partner, because in the OR it's quite cold. So the baby stays with the partner for the rest of the time, and they will stitch you. And when you're ready, you're going to join, of course, your partner and the baby. They're going to all explain you what I mentioned earlier at that moment itself, how it's going to work, but maybe good to know as well on this moment already that that can be a reason. There are different ways of cesarean as well. If it's a planned cesarean, you can have a gentle cesarean as well. Then they are going to warm up the OR, and then the baby can stay longer with you. That's only possible if it's a planned cesarean. So if, for example, at the end of the pregnancy, the baby is in breech and you know that it's going to be a cesarean, then it's something you can discuss with your gynecologist as well. If it's an emergency cesarean during labor, then it's not possible to do that. During labor, there are also different reasons to be referred to the gynecologist. The biggest reasons to be referred is pain relief. And we're going to talk about that in the next slide, the different ways. But good to tell you the other reasons to be referred as well. One of them is meconium. It's what Lotte mentioned already earlier. It's when the baby pooped in the water and the color is brown or greenish. Then it's good to determine how the baby is doing. They will give you a heartbeat monitoring device where we call it a CTG. They monitor the heartbeat constantly during the rest of the labor, and they monitor also the amount of contractions you're having. If you don't have any contractions yet, at that moment, they're going to induce labor at that point. Another reason to be referred is a slow or stunted progression. When we do see that you have regular contractions, but the dilatation is not going further, or when you're pushing, the baby is not going any deeper, then it can be a reason to be referred as well to a gynecologist. Depending on the phase or the moment when that's happening are the next steps. So sometimes it can mean that you need a drip with oxytocin to make stronger contractions so that the dilatation goes further, or you have better contractions to push the baby out. If it happens sometimes already during the pushing stage and the baby is already really low, it can be also a reason to do a vacuum delivery. A vacuum delivery is where they place a vacuum on the head of the baby, and you still have to push the baby out. But what happens with a vacuum is that what we mentioned earlier, the head of the baby goes 3 steps lower, and then when the contraction ends, goes 2 steps back. a vacuum makes that the head doesn't go back, so it keeps it on place, and that's why at that point it goes much quicker. Another reason to be referred to a gynecologist can be a deviating heartbeat. What I mentioned before is that we monitor the heartbeat of the baby really carefully, and it's okay, especially during the pushing stage, that it reacts a little bit on the contractions, but of course there's a limit on that. If we doubt about the heartbeat, then it's also a reason to be referred to a gynecologist. Then they put the CTG belts on again to monitor the baby more carefully. Sometimes they do extra tests where they take a drop of blood from the head with a scratch on the head of the baby to determine a couple of things, to see if the baby's doing okay or not. Sometimes it can be a reason to do also a vacuum delivery or to do a cesarean. And then it's what I mentioned earlier, the cesarean, which is an emergency cesarean. So it's done immediately at that moment. A last reason to be referred to a gynecologist is a postpartum hemorrhage. It's where you lose too much blood after birth. We determine and look a lot at the blood loss after the baby is born to see if it looks normal. If it's more than average, then we give you medication, what Lotte was mentioning. But if we still think it's too much, then we refer you to a gynecologist because he can give more medication for that.
Then I'll tell you something about pain relief. First of all, it is possible. It's good to know that also in Holland, it's possible to have some pain relief, and it's quite common. So don't worry about that. I will tell you about the different options of pain relief, and our advice is not to choose right now, like this is my option, but just to know that it is there. Most women go in labor and just say, okay, I just see how it goes. And many women do not want pain relief and do not need pain relief, but most times it's impossible to tell before the delivery starts if you need it or not. So our advice is just go in labor and see how it goes. And if you want some pain relief, we will help you at that moment to tell you again what the options are, and then together we can decide what kind of pain relief you want. But I will tell you now so you know what are the options. As a midwife, there are several things we can give, and for some things we have to refer you to the gynecologist. What you can use yourself at home or in the hospital is a TENS machine. It's a machine that you can rent from your insurance or that you can buy online. Birth TENS it's called. It's a machine that is attached with wires to like a sticker, and then you can place that sticker on your lower back. And when you press on the button in the machine, there will be a small electric tension going between those wires, and that is making the pain less. It's not taking the complete contraction, the sensation away. It's just blocking a little bit the pain sensation that's going to your brain. So you're experiencing less pain sensation. Our experience is that it can be helpful, especially with women who are experiencing lower back contractions. If women experience the contractions in their legs or in their belly, this is not a very effective way of coping with the contractions. But if you have contraction in your lower back, it might help you. Another option is the use of gas and air, Entonox. That is something that you cannot use at home because it's a whole system that you're going to use. So you can only use that in hospitals where they have those systems present, and that's in the OVG West and the Amstelveen Hospital. Gas and air, it works for about 5 hours. You will have a mask that you will put on your face, and when you breathe in, the gas and air you will breathe the gas and air, and that will help you to cope with the contractions, because it will really make you very calm, relaxed, sometimes a little bit dizzy in the beginning. And what I said before, that the contractions is like a wave. Now you still have the wave, but you don't feel it that much. So it's not like a very big peak, it's just little bit, lower intensity. And also when the contraction is gone, women experiencing more relaxation. So it looks like they're asleep when the contraction is gone. It works for about 5 hours, and that's why it's a very effective pain relief at the end of the delivery. So when we know that you're going to give birth within 4 or 5 hours, and you just want to get like the edge of the contraction, that you just want some help with the pain, then gas and air can be a really good option. The good thing is that when you're in the hospital, the OVG West or Amstelveen, and you ask for it, it can be administered to you very soon. And because you're giving it yourself with a mask, you can determine if you want to use a lot or just a little, and you can just find it out during the contractions if it makes you feel comfortable or not. It's not affecting the baby or the contractions, so it's a very safe way of pain relief. So the contractions stay as strong as they were before, and the baby is not affected, so we do not have to do any extra checkups with the baby. Another very good pain relief is taking a bath or a shower. A shower is possible in all hospitals and also, of course, at home. A bath is sometimes possible at home if you have your own bath, or you can rent a bath. On our website we have the locations of places where you can rent a bathtub, specially made, designed for a birth. In several hospitals they also have a bath. That's in the OVG East, West, the Boven Ei Hospital and Amstelveen Hospital. You can go in the bath when you're experiencing contractions, even when the membranes are ruptured. As long as you have good contractions, you're allowed to go in the bath. It can be a really helpful way of coping with the contractions. A lot of women experience much less pain sensation when they're in the water. You can just try it. If you like to, you just stay in there even during the pushing state, but some women just don't like it and go out of the bath within an hour. It's really a good thing to know that it's an option. Then there are other possibilities, like remifentanil of an epidural. Both those pain reliefs having effect on the baby. It's a healthy baby can cope perfectly well with these kind of medications, but we have to be sure that the baby is in a perfect condition. So if you would like to have the remifentanil or the epidural, we will refer you, and the gynecologist will do the CTG scan again, so it will measure constantly the heartbeat of the baby for about half an hour. And then when it's confirmed that the baby is in a good condition, they can start giving you the remifentanil or the epidural. I will tell you what the difference is. The remifentanil, it's an IV drip, so they place an IV in your arm and it's attached to a button. And when you press that button, a small amount of the medication will go in your system, and it will really make you very calm, relaxed, and it will also decrease the pain sensation during a contraction and makes you feel really relaxed when the contraction is over. It's quite similar to gas and air, but a little bit stronger than that. The remifentanil, you give it yourself with a button, and that's also nice. So if you can never overdose yourself, because there's a protection, so you can't just continue pushing. The good thing is when it works quite strong on your system and you just don't like that feeling, you can just skip 1 or 2 times, so you just don't push the button, and then it goes out of your system very soon. Within like 10 minutes, it's completely out of your system. So you can dose it yourself. The effect on the baby can be that it's more the effect on the mother that's affecting the baby. When women having remifentanil, they sometimes start breathing very superficial, so not very deep anymore. So the oxygen level in your system as a mother can go down. And that, of course, can affect the baby. And we know that, so that's why the gynecologist will check your oxygen level constantly and check if your breathing is still okay. If the gynecologist sees that you're not breathing very deep anymore, they will sometimes ask you to stop pushing, so you can take a deep breath again. And when they see the oxygen level is too low, They will stop the medication, like for 1 or 2 contractions, and sometimes give you a little bit of oxygen with a mask. And then when everything is in normal levels again, you can start pushing again. But that's why we as a midwife cannot give it to you, because there have to be done extra checkups and extra monitoring of you and the baby. The remifentanil, just like Gazenair, works for about 4 or 5 hours. So if we think you need the medication, the pain relief, longer than those hours, it's not a very good pain relief. Because if you would have this medication, for example, at 2 centimeters dilatation, and it's still going to take like 10 hours before you're going to give birth, by the time then you have like 5-6 centimeters dilatation, this medication won't work anymore. So we only advise Gazenair or the remifentanil when we think the baby is born within those 5 hours. So most times that means that we can give this to you when you have more than 5 centimeters dilatation. Then there's an option of the epidural. An epidural is given by the anesthesiologist. So if you decide to have the epidural, the gynecologist will check the condition of the baby again with the CTG for about half an hour. Then they will call the doctor in, and they will come in to place the epidural. The whole process of placing the epidural will take more or less about 20-30 minutes. But sometimes it can be quite a while before you have the epidural, because first we have to check the baby's condition, then they have to call the doctor, and they will come as soon as they have the possibility. But for example, when they're in an operation, sometimes it takes a little bit longer. It takes about 45 minutes or an hour before they come to the delivery ward. So it's good to know that that can happen, that can occur. If it happens, then sometimes the gynecologist will advise you first to start with remifentanil until the doctor is available and comes in. If the epidural is positioned in the right spot, then you don't feel anything anymore. Then from the uterus down to your legs, you don't feel any pain sensations anymore. So it's the best kind of pain relief there's available. Some women still experience a little bit of the contraction. They feel some pressure or a little bit of pain, but it's always much less as what you experienced before. But they try to make you feel completely without any pain. The good thing with the epidural is it can be in that it works for as long as we want to. So if you're in an early stage of labor and we think you might need pain relief for quite a while, this is the best option. So when you have like 2 or 3 centimeters dilatation and you need pain relief, this is the best option because it can be given to you until the moment you have to start pushing. All kinds of pain relief we will stop when you have to start pushing, because we know that it's very hard to push when you don't feel the contraction anymore. So with the remifentanil, they will stop it completely. With the epidural, they will slow it down or turn it off completely, depending on how good you can push when you're not feeling the contraction. Unfortunately, an epidural also has negative side effects. We have some information at the practice about all different kind of pain reliefs, and that summarizes all the negative and positive things about the epidural. But the 2 things I want to tell you, because they're most important, is that you sometimes see that the blood pressure of a mother drops when we give the epidural. And because most women already have a quite low blood pressure during the pregnancy, the gynecologist will give you some extra fluid in your system to first get your blood pressure up a little bit before they can start the epidural. So just in case the blood pressure drops, that's not a problem then anymore. Another thing that can occur during an epidural is that your own temperature goes up, so that you will have a fever. Most times it's caused by the medication that's in the epidural, but we don't know for sure at that moment. So the gynecologist will then start giving you antibiotics with an IV drip to make sure that if it would be an infection that caused the temperature to rise, that's treated as soon as possible. They will also take some swabs to check if there's an infection. When the baby is born, while you are taking antibiotics, the baby will also be treated with antibiotics for about 2 days. So then you have to stay in the hospital after the delivery for 2 days or until the result of the swabs come in. And when they see that the swabs are negative, so there are no signs of an infection anymore, then they can stop all the antibiotics and you can go home. But so in case your temperature goes up, you will get antibiotics and the baby as well, just to be 100% sure. Again, we can give you this information again when you're in labor. So when you will experiencing too much pain, tell us, because then we can help you and talk about it. We won't ask you every contraction, like, are you okay? Do you want pain relief or not? Because it's very hard if I would ask you every contraction, like, can you do it or do you want pain relief? But at the same time, we have to find the balance that when we think someone really needs pain relief, we sometimes actively gonna advise you to start with pain relief. But it's finding the balance between staying positive and telling you that you can do it, at the same time not telling you too late that it's still an option to have the pain relief. So the best thing you can do is just go in labor, stay positive, but the moment you think that you can't do it anymore, then just ask for the options and they will tell you again what the options are, and then you can decide if you want it or not.
Then we would like to tell you a little bit about the place of the birth. Of course, we mentioned it already a couple of times that you have the option here in Holland to deliver home, at home, but you can also decide to deliver in the hospital. It's where you feel comfortable and what you want. If you decide to deliver at home, there are some preconditions where your home has to fulfill. Because it has to be safe to deliver at home. What that is that you have to be able to leave the house horizontally. So that means that you or have to live on the ground floor, or have to have an elevator in the house, or there has to be big windows through the street side where, if it's necessary, if there is an emergency, the fire department can lift you out of the house through the windows. That's really rare. I've never experienced that myself, but it should be an option. So at the moment you decide that you want to deliver at home, we always check your house if it's at the moment itself, if it is okay to deliver at your home. You don't have to decide it now already in the pregnancy, you can, but it can be also something you decide the moment itself. Because we have actually experienced a lot of times that people say, well, I really want to deliver in the hospital, but the first time we enter their house and it goes really well and they think, okay, actually I feel quite comfortable at home, they decide to stay at home. But we also have it the other way around, that people say, I really want to deliver at home, but when the contraction starts, they think, well, actually they're much more intense than I thought it would be. I would rather go to the hospital and it feels better there. Maybe I have the option of pain relief there as well. So you can decide prior to the delivery, but know that you can always change it the moment itself, or decide at that moment. If you decide to deliver in the hospital, you can go there with your own transportation, so your own car, or if you don't have a car, what a lot of people don't have in Amsterdam, then you can use a cab. A lot of people think that cab drivers won't take you, but actually, what I said, a lot of people don't have a car in Amsterdam, so they're really used to transporting pregnant and delivering babies, women, so it's really normal for them. Good to know that a lot of hospitals, or a lot of times, if you want to deliver in the hospital, there are some costs for that. It's depending on your insurance, how much that is. So it's good to check your insurance, what they cover. Most of the times, if it's your own choice to deliver in the hospital, it costs you like 300, 400 euros to deliver there. But check your insurance just to be sure. What I also mentioned already earlier, what we mentioned is that there are different kind of hospitals. In Amsterdam, we have 5, 6 of them. And also that you can decide already now which has your preference, but you can also check at that moment which feels good. the moment you're in labor, we'll always come and visit you at home first. So you're gonna call us and we'll come to your place and check how much dilatation you have and how everything is going. At that moment, we're gonna ask you, where do you want to deliver? If that's in the hospital, then we'll go with you together to the hospital. But we're gonna call at that moment the hospital of your first preference to see if they have space. Once in a while it happens that they don't have space, and luckily we have several other options then to go to. So if you want to deliver in hospital, it's always possible to deliver in hospital, but there is a chance that it might be not the one of your first preference. Then a small bit about the postnatal period, because we can talk a whole nother evening, day about this. So it is good to really prepare yourself for this moment as well, because it's such an important moment and time. Good to know for now is that what Lotte was saying, for the first week the maternity nurse comes to your place to take care of you and the baby. She does checkups and also assist us when there is home delivery. We'll come and visit you also in the first week and have a lot of contact by phone as well to see how everything is going. We're responsible for you that first week, so if there's anything, please call us, and you can always call us at that moment on the emergency number.
I cannot tell you everything about breastfeeding right now, but there's a lot to know about breastfeeding. Most important thing to know is it takes time. It's not that easy as what it looks like. You have a baby that's hungry and a breast with milk, you just attach them to each other. It just takes time. It's like riding a bike. So don't expect the baby to latch on right after birth perfectly well. We will be there to help you how to latch the baby on, and of course the maternity nurse for the first week will help you a lot with that. But it really helps a lot when you know a little bit beforehand what you can expect when you start to breastfeed. So my advice would be to read the growth guide about breastfeeding. Probably you had this one from us at the practice. If you didn't receive it yet, ask for it during your next appointment. Read it during the pregnancy, because when the baby is born, you don't have any time anymore to read. And if you have the time, try to see if you can go to one of the meetings about breastfeeding, or there's also some online videos available about breastfeeding in the first week. What are the things we really want you to have at home by the time you're 37 weeks pregnant is the maternity package. It's a box that is most times sent to you by the insurance company around 36 weeks. Sometimes it's not, and then you have to buy it yourself. You can buy that with us at the practice or at your pharmacist. Another thing is it's very important that the bed is raised up to about 70 centimeters. So my advice is go to your bedroom and just measure it. How high is your bed right now? If it's less than 70 centimeters high, you have to raise the bed. That's for us and for the maternity nurse to have like healthy working height. It's not something that is optional. You really have to do it. Also, if you want to deliver in the hospital, the bed has to be raised. And you can get Klossen for those, bed raises. You can go to our website, to the address book. There you can see at home care how you can order these bed raisers. Another thing that's important is that we can find you. So it's nice if you have something on your door so we know which doorbell we have to ring. We have this at our practice. Put that, it's a sticker, put that on next to your doorbell or on your doorbell. So when we come at night, we know how to find you. And also the maternity nurse and the pediatrician center who will visit you the first week find it really handy if you place that on your doorbell. Another thing is nice if you have prepared is your delivery bag. Even if you want to deliver at home, it's nice to have like one bag prepared with clothes for yourself, clothes for the baby, your ID, your phone, your charger, maybe some candy bars or things you really like to bring with you, a warm water bottle, things like that. So in case we want to go to the hospital, you don't have to collect all those items during the contractions. Of course, a camera is very nice to bring. You can do that also with your phone, but then make sure you also bring a charger with you. Baby clothes, it's nice to bring like 2 sizes because we don't know exactly how big the baby is going to be. So bring like a smaller and a little bit bigger size baby clothes. It's important to have at home a thermometer, a rectal one. You can buy that at the ATOS or the pharmacist. And it's nice to have a car seat because if you deliver in the hospital and you bring the baby home from the hospital, it's the only safe way to bring your baby home is in a car seat. If you don't have a car yourself, it might not be necessary to buy a car seat. Then it's also possible to rent a car seat, or maybe you can borrow them or just check online if people sell them secondhand. This was our presentation. We hope you enjoyed it. Normally we give this live, so then this is the moment that you can ask us all the questions. But that's not possible now, but of course we will see you again at the practice. We and our colleagues know exactly what we told you today. So if you have any questions, don't hesitate to ask them during your next checkup. Write them down and then we will answer all of them. Thank you very much, and then we wish you an amazingly nice birth and a very beautiful baby.